it's my perspective. After 13 or so years in the ER, I've seen lots of death. I've seen lots of disease. I've seen lots of suffering. To me, I've lost loved ones from cancer. There is just, Alzheimer's hits differently.
Yeah.
It's the cruelest disease I've ever seen. And not necessarily to the person suffering from it.
Right. Right.
It's the people who love that person the most, because that person is losing their vault of memories, their identity, their history, their past, their relationships. It is profoundly impactful in a negative way to the inner circle of those people. And it just, it's a unique, has a unique cruelness to it. And so I'm incredibly sympathetic to people who walk through that. Again, fueling this fear and real heightened sense of, I do not want that thing.
Right. Yeah.
As we move into section 2 of this talk, it's really about new screening modalities, diagnostic tools, imaging. While I would love to give you a laundry list of new and exciting breakthroughs, those things don't exist. There are a lot of studies, there are a lot of things, irons in the fire, trying to elicit something that we can identify that actually makes a significant move in outcomes for people who have it, or in a prevention. Those aren't online yet. There are a couple things that we should be doing, because we do have access to them, that while they don't provide a smoke and gun as a diagnosis early, they can be markers for, dig a little more here. They could be early indicators. And some of them are as simple as things that we do in the office, like in-office memory testing, attention, problem solving. Many of these we've used a couple of them. They're iPad-based. They're a few minutes. And even if they don't flag, they establish a baseline. So annually you can see some drop off. Those can be early indications. It could be that you have a lot going on in your life and you're just not paying attention. It also could be that you're losing some of the acuity and the crispness of your thinking. Can be an early marker. So in-office screening tools, if you're listening to this, your primary care should have access either to these in-office tools, or there should be resources to someone in your community that has access to these tools. We lean heavily on advancements in diagnostics as far as like blood work and imaging. The most pertinent, according to me and you, in the way we practice, is something called the APOE genotype. So E is an echo, APO, APOE. We all have an APOE gene. Each gene has 2 copies, one from mom, one dad. We call that the genotype. You need an APOE genotype, and what we're looking for is a type 4.
Yeah.
4 is unique in its association with early cardiovascular event and early onset Alzheimer's. I'm not really sure the mechanism. Are you aware of the mechanism?
I think it has to do with lipid metabolism, if I'm not mistaken.
Yeah, I think you're probably right. I'm not sure exactly, but nonetheless, it is a huge marker. Again, not a smoke and gun. Doesn't mean you're going to get anything, but it means this is a clearly identified risk. And if you have a copy of another gene and a 4, that's a partial risk. But if you have a 4 and a 4, this is someone, and I believe the patient you're talking about is a 4-4. This is somebody who should be at the top of the list as a heightened sense of awareness, that maybe do all the things and keep maybe a few extra. Just a real sense of like awareness. We also been talking a lot about metabolic disease in other content we create, whether it's talking about diabetes, heart disease, cancer, or any other metabolic disease. I'm most interested in the current thesis, and this has not been proven, but it's starting to build quite a compelling case that Alzheimer's may need to be considered more of a diabetes type 3 phenomena. Again, you know, if you've spent any time in doing any research on Google, you may have come across some of this language. Again, meaning that the root cause of this disease is really nothing more than a brain manifestation of diabetes, insulin resistance at the level of the brain, which is insane to think about. But nonetheless, metabolic screening, so your lipid panel, all of the things that we've talked about before with cardiovascular stuff, so your particle number, your fasting insulin levels, triglyceride to HDL ratios, et cetera, et cetera. All of these things that could give us a clue that you're insulin resistant. It's not just about heart disease. It's not just about fueling the flames of cancer or obesity, but we are potentially also talking about cognitive optimization. And if we're not talking about Alzheimer's, we definitely are talking about the other type of most common type, which is vascular dementia, which you end up getting from having high blood pressure, diabetes, having little strokes, and your brain tissue just gets beat up over the years and you get dementia because of that, but it's not Alzheimer's type.
Right.
It's about 10%. I think when you did your research, it was 60 to 80.
60 to 80 Alzheimer's, 10% vascular, and then a mix was the third type.
Yeah. And then there's some others, Lewy body dementia, some other things that's beyond the scope of this talk. This is really about dementia, and not all dementia is Alzheimer's, but all Alzheimer's is dementia. Alzheimer's is really the thing that we're most scared about, but number 2 on that list is vascular dementia, and what component of Alzheimer's is more of a vascular phenomenon because of metabolic disease? Stay tuned. I'm not sure that you can separate them completely. We also look at other, maybe not so obvious diagnostic stuff in office. Again, as an extension of metabolic efficiency, we look at body composition, measuring visceral fat, waistline, blood pressure, daily weights at home, heart rate monitors, sleep monitoring, anything that could show a pattern that would be concerning, that we should spend more time. Again, none of these are diagnostic, but you start building a compelling case. If they're all clear, or you start stacking things that are not clear, you should probably make different decisions and execute different decisions.
For sure.
Obviously, imaging. If somebody has, if you're off on your baseline thinking, some sort of imaging to make sure that we're not dealing with some sort of increased pressure in your brain situation, potentially a brain tumor, potentially you've had some strokes. So a CAT scan or an MRI are usually indicated at least early on in the workup. And then I want you to talk a little bit about this here, because this is real life for us. We're learning about a lot of these brain health centers. I think most major markets across the country have, usually outside of insurance, usually outside of the standard kind of operating procedures of workups, but they're catching a lot of momentum because they're digging in a way that feels much more handcrafted and thoughtful. And these centers tend to be doing things like a quantitative EEG, so a QEEG. So EEG is what you use to see if you have seizure disorder and brain. So it's measuring brain waves.
Yep.
And then there's a special kind of CAT scan that uses a radioactive particle in a dye. It's called a SPECT scan. And through this type of imaging, we're able to recreate a 3D image of the actual brain structures, both externally and internally. And normal brains tend to look certain ways. Certain diseases tend to have certain patterns in the tissue. So these, you can kind of extrapolate potentially the health of the brain based on how it looks on a 3D rendering, which is really fascinating. Why don't you speak a little bit about these brain health centers? Because I think for many, many people, this is like, oh, that's cool, and then that's it.
Yeah.
But if this is a topic that's really hitting for you because of your family history or your risk profile, or you're in your 50s and 60s, and you're actually, in your own assessment, I'm losing my crispness and I have some concern, and I'm told I'm okay, but am I doing everything? This might be a discussion worth having. So talk about your experience with.
So we have a specific member that I mentioned earlier. Mother has dementia, is going through, watching her mom go through that, and she's an ApoE44. So we already identified that she's got
Plenty of risk factors.
family history and the genotype. And so I researched out some different solutions for her, really to just relay her fear, because she's in a place right now where she's doing a lot with the modifiable risk factors. She's basically an athlete from a fitness standpoint. She eats very clean. But she just wanted to learn more and see if there was a way to kind of optimize her brain health. So the Amen Clinic, AMEN Clinic, it's they have a location in Atlanta and Chicago. And listen, we're not saying whether they're good or bad. They just exist. They will do the brain scanning. They will do a full workup, basically, consultation, and then give you a plan for either optimizing your brain health or kind of a preventive strategy, not really preventive strategy, but improvement strategy on your cognitive.
Based on what they find on their testing.
Yeah. It could be adding some micronutrients. They test the micronutrients to just see if you're deficient in something. They do the brain scanning. And then you can follow back up and see if it's improved, which is pretty cool, because a lot of times there's not a good way to see if something's working. And so they'll, tell you, which is great.
Yeah, and look, I mean, there are no shortage of places that you could go to get, let's call it brain testing done. But there aren't many that are going to be able to provide true imaging reports, objective data that from you can create a thesis around what's going on, and then execute a plan against that thesis, and then retest to see if there's improvement.
Yeah.
Which is really interesting to me.
If you were to go to a neurologist tomorrow, they would do the standard EEG, probably some imaging.
And say everything looks normal.
They would look at the structure and function of your brain, the vascularity of your brain. They wouldn't be able to tell you if your brain's going to perform better.
It's not an optimization program. It's do you have disease, yes or no?
Right.
And unless you have glaring disease, you're normal. But there's no mechanism in any of the healthcare current model, because we have sick care, not healthcare. We're designed to identify and treat disease.
Yeah.
And since there is no treatment for Alzheimer's, all we're saying is you got to go on the offense and find it early. So our only play is diagnostics.
Right.
And those are limited. So then you really hyper narrow down into optimization. And so in your path to optimize your thinking, whatever mechanism you want to measure, if you're not optimal or incapable of getting optimal, or there's a decline that's measurable, that could be, it doesn't mean it is, it could be a sign that we've got early Alzheimer's or Alzheimer's at play.
Yeah.
At which point you potentially could intervene and stall that out.
Yep. It's pretty
That's
fascinating.
a big deal.
Yeah.
I think as we close this second section, it's really about early detection and delaying, because you can't really prevent it, and you certainly cannot reverse it as of the summer of 2022.